Okay, everyone. Hello. Welcome back to the Med-Surg tutoring. I am so happy that I have participations. You guys coming to the tutoring. So before we start, again, if you guys watching this as a recording, please also scan the code so that Mrs. Dubose know that there are students attend to these tutoring session. And I can keep my job. So before we start, just clarification, everyone can hear me okay? I'm in the library today, so there's maybe background noises. I'm really sorry about that. But other than that, you guys can hear me clear and loud? Perfect, thank you. Okay, so today we are going over the topic of inflammatory and structural disorder and shock. So these topics come up on the first exam a lot. So it's a very short and not very hard topic, but it will be covered in the exam. So this is the topic to study before the exam. I believe you guys have the exam next week, correct? Okay. All right. So don't worry. Let's ace this topic first, and then before the exam next week, I'll have a good review for you guys. And after today's session, I'll post some of the Kahoot link that Sarah, one of the member in my cohort, she made it, so you guys can practice some questions. Okay, let's get started. So the first thing that you're welcome. The first thing that we are going to talk about is the rheumatic heart disease. So this is one of the inflammatory disease of the heart. This is one of the inflammatory disease of the heart. It causes damage to the heart valves. It caused by rheumatic fever. It begins with a strep A throat infection. And the symptoms are fever, arthralgia, skin rash, pain, and white patches. Complication often seen after 2 to 3 weeks after the strep infection. So the most important thing about this I would study is the strep infection that is the main cause of the rheumatic heart disease. So the rheumatic heart disease will cause erosion and damage to the valve. And because the valve is very important for the heart, if there anything that happens to the valve, it will let the valve not shut all the way and causes pulling of the blood, regurgitation, and fluid backup. So in our heart, we have different chambers, and what separated those chambers are the valve. The heart able to flow into a new chamber or not being flow backward to the previous chamber is because of the valve. And having rheumatic heart disease will causes damage to this valve, and it will lead to the blood being back up. And whenever the blood being back up, it will causes a lot of issue with the lungs and crackles. And rheumatic heart disease or inflammatory disease of the heart usually occur with the valve on the left side of the heart. So can anybody tell me what is the left side of the heart? The left side, the valve on the left side of the heart. You guys comment. What is it called? What is it called? Yes, it's called the mitral valve. Good job, Juan. So it is important to know very clearly the name of the right valve and the left valve, so that you guys can distinguish them in the exam. So the left side valve of the heart is the mitral valve. All right. Infective endocarditis. So infective endocarditis is the infection of the inner layer and valves of the heart. Risk factor is poor dentation, IV drug abuser, valve replacement, dialysis. So here I highlighted the poor dentation. It is very important. Patient who often have infective endocarditis, one of the main and popular cause is poor dentation. Clinical manifestation is fever, anorexia, petechiae, splinter, hemorrhage, painful oscular nodes, fatigues, murmurs, and heart failures. Diagnostic are blood cultures, which is going to be done first, chest X-ray, ECG, echocardiography, heart catheterization, ESR, and C-reactive protein, which will be increased. Nursing care, we need to identify the organism, so which is very important before we start the antibiotics. So whenever she mentioned about infective endocarditis, please remember one of the first thing we're going to do is the blood culture. This is the first and foremost thing that we're going to do, because we need to identify which bacteria or which virus are attacking the valves or the heart before we can start antibiotics. And they will be on IV antibiotic, or they can have a valve replacement for severe damage, antipyretics, which is medication for fevers, and fluids. So infective endocarditis is basically an infection of the actual heart muscle, because the heart muscle is being damaged. Also, it will not pump effectively. So again, when it does not pump effectively, the fluid will be retained in the chamber, or it can back up. So if the fluid is being retained in the left ventricle, it can be backed up to the left atrium and back up to the lung, which can cause this issue with the lungs. So you guys can hear crackles in the lungs, just because the heart muscle is not being pumped, is being damaged because of the infectious agent. So so in these in the pictures that she's going to show you guys tomorrow of infective endocarditis, there will be these green things that on the muscle of the heart, and those are the infection, and they are called vegetation. It is because the body produces platelets that causes fibrin production. So these platelets will clump into the infectious area of the heart, and will causes things that call vegetation. And that will be, whenever we talk about vegetation, we know that are the infective endocarditis, because it's specific for the heart. So vegetation is equal infective endocarditis. So if there's a question on the exam mentioning the patient is, there are vegetation found on the patient heart muscle, immediately choose infective endocarditis. So typically it is stemming from rheumatic heart disease, and rheumatic heart disease is caused by rheumatic fever. Some of the diagnostic are blood cultures. So the blood culture will show us if it is a strep A blood infection. Then which is we're going to do first. If the patient is suspected having infective endocarditis, we do first and foremost, we do blood cultures before anything else. Then we can do chest X-ray, which can show the enlargement of the heart. Usually the heart will enlarge when it's not pumped effectively, because when it's not pumped effectively, the heart automatically try harder. And when it try harder, or like, it's just like we go to the gym, we train our muscle, it will get bigger. So the heart have to pump harder, faster, so it will be enlarged. And an enlarged heart is a bad heart. We don't want enlargement of the heart. ECG show heart blocks. Don't really need to know the heart block because we don't even go over it in class. Echocardiography, it will show how well the heart is pumping. Heart cath is the heart catheterization, which will show us the visualize of the blockage or the backflow of the heart. ESR and CRP high because they increase inflammation and infection in the body. So whenever we have an increased inflammation or infection in our body, the lab ESR and CRP in our body will be high. And the antibiotic will be given for 4 to 6 weeks, and it will going to be IV antibiotics. So we just help the patient rest and give acetaminophen, which for the antipyretic properties, given for fever and to decrease workload of the heart. Okay, next we have pericarditis. So pericarditis is the inflammation of the pericardial sac. It is the fluid sac that surrounds the heart that got inflamed. Clinical manifestation is progressive, severe. Patient will feel sharp pain, worse with inspiration and dying and lying flat. So the patient will experience worse pain whenever they breathe in or whenever they're lying flat. Hallmark of the pericarditis is pericardial friction rub. So whenever in the exam, she gives you a sign or symptom of pericardial friction rub, immediately think about pericarditis. Complication. So the complication is pericardial effusion, cardiac tamponade. Diagnostic, EKG, chest x-ray, echocardiogram. Treatment, we treat the cause, NSAIDs, steroids, pericardial centesis. Pericardial centesis is basically insert a syringe and then we remove the fluid from it, and the doctor will do it. And of course, NSAID and steroid is used to treat the inflammations. Again, it stems from rheumatic fever. So to relieve the pain, as nurse, we tell the patient to sit up and lean forward. Don't worry about this next part. Next, we have pericardial effusion. Pericardial effusion is too much fluid. This will compress the heart even more, causing distant and muffled heart sound. Because if you think about it, the heart is like underwater. So pericardial effusion is basically because the inflammation of the sac, the fluid put a lot of pressure in the heart. So the heart's being compressed, so it cannot pump effectively. It have to work so much harder to pump because it's being compressed. So we will hear distant and muffled heart sound. Cardiac tamponade. Cardiac tamponade is developed as pericardial effusion volume increases and keeps compressing the heart, causes more severe sign symptom. For example, neck vein distension, the carotid vein distension right here. No, not the carotid, but one of the veins on the neck distended. Tachypnea, which is a fast breathing and decreased cardiac output. Decreased cardiac output, why? Because the heart is being compressed. It cannot pump effectively. So the amount of cardiac output is produced to go out the aorta is limited or decreased. ECG is to see the changes. Will you guys see the changes in rhythm and severity? Chest x-ray is to see the amount of fluid or the enlargement of the heart. If the cause is from an infection, we give antibiotic, and NSAIDs will help with the inflammation and control the pain. So again, pericarditis is basically the sac is being filled up with inflamed fluid, lead to restrictive contractility. Like I said, the heart being compressed by all of the inflammation, all of the water in the sac being compressed so that it cannot contract normally. And because it doesn't contract normally, as a result, the heart will fail. It causes heart failure. Heart failure meaning the heart doesn't pump or work effectively or or function as it should do. We'll see the sign of fluid overload or fluids in the lung. because heart failure, one of the biggest side of heart failure, left side heart failure, is crackle in the lungs. So we hear the crackle in the lungs. Yeah, and how to fix them? We do paracentesis, like I mentioned earlier, using the syringe to remove the fluid from the sac. If the patient unable to breathe because of the backup fluid into the lung, we do tripod position and sit up the patient up higher. Tripod position is the position where the patient sit, and then the two arm is like this and put it on the table, kind of like a triangle, so like the patient can like breathe better. NSAIDs steroid is targeting the inflammatory. Diuretic, we can give diuretic as well to treat the overload of the fluid. So the key thing in this, you guys need to remember is the manifestation, which is the chest pain and the pericardial friction rub. Pericardial friction rub is the hallmark of pericarditis. Whenever there's something in the exam, mention that, immediately think pericarditis. Yeah, pericardiocentesis, needle in the outer layer of the heart and drain the fluid. All right, valvular heart disease. So valvular heart disease is a topic that messed up a lot of my friends last semester in the summer. A lot of people didn't pass the first exam because of valvular heart disease, because we thought it wasn't important. However, she put probably like 8 questions of valvular heart disease in there. A lot of questions about this topic. So I would really recommend you guys study this topic, watch YouTube in your free time before the exam that specifically targeting valvular heart disease. So valvular heart disease, we have 2 types, stenosis and regurgitation. What is stenosis? Stenosis is hardening, constriction, narrowing, blood is not flowing. So basically, stenosis valve is when the valve, it doesn't open big enough for the blood to flow in. For example, we have blood flowing into the right atrium, and from the right atrium, it has to pass the valve, the tricuspid valve into the right ventricle, and the tricuspid valve is stenosis, is hardened, so it doesn't open up. It doesn't have a big space between the two the valves, so the blood cannot fully go into the right ventricle. So that's stenosis. Regurgitation is when the valve is not closing, or is not closing enough. So it's like the door, it's like the 2 door that is not closed. So the blood coming through the right ventricle, the right atrium to the ventricle, and then the valve doesn't close enough, so the blood in the right ventricle got backed up into the right atrium. So that regurgitation, and it will result in backflow of the blood. So both of stenosis and regurgitation, again, will lead to decreased cardiac output. Yes. And usually valvular heart disease is typically on the right side of the heart. No, not really. Don't cross that out. I don't think so. Usually it's caused issue with more the left side, not the right side. Next, we have mitral stenosis, and that's the reason why, because we go over a lot about the mitral. So focus on the left side of the heart more than the right side. It's not typically on the right side of the heart. It's typically on the left side of the heart. Left side. Okay, so mitral stenosis. Mitral stenosis is mitral valve, like Juan mentioned earlier, it is the valve on the left side of the heart. It is the valve that separated the left atrium and the left ventricle. So stenosis, what is stenosis? Stenosis is the door that is not open big enough for the blood to flow. So that's stenosis. So mitral stenosis is the door on the left side of the heart, the mitral valve. The forward flow of the blood through stiff stenosis valve. Rheumatic fever is the most common cause. Emboli can form. The reason why emboli can form is because whenever there are blood that is being retained in an area, it will form clots because the door is not open big enough. So not the whole volume of the blood being distributed to the left ventricle. So that's why there's a little bit of blood retaining in the left atrium. So that's why it will form, causes pooling and causes clots, emboli. Clinical manifestation is murmur on S2, pulmonary congestion, crackles, bronchi, neck venous distension, pitting edema, and AFib. So we can see that it is a lot of issue with fluid, right? And especially pulmonary crackles and bronchi targeted lungs. The reason is because when the blood is, the reason is because it's on the left side. It is where it's right connected to the lungs by the pulmonary veins. The lung deliver blood to the left atrium through the pulmonary vein, so it's right there. So anything happen to the left side, it will cause this backflow of the blood and also blood pooling in the lungs too. So it causes a lot of issues with the lungs. And the really important thing to remember is the murmur on the S2. I will explain more on that later, but it causes a lot of issue with murmur on the S2. That's really important to remember on the exam. On the exam, she'll ask you like, which S1 or S2 is specifically with mitral stenosis. So with mitral stenosis, it's going to be on S2. Next, we have left-sided symptom. If emboli can form, think of what you might be needing to give the patient. So if emboli can form, we give anticoagulant, yeah. Next, we have mitral regurgitation. Mitral regurgitation is backward flow of the blood through incompetent valves. So regurgitation is the door not closed good enough so that the blood which has been distributed from the left atrium to the left ventricle be backflow into the left atrium. Rheumatic fever is the most common cause, also caused by MI, myocardial infarction. Clinical manifestation is S1 murmur, poor pulses, core extremity, and AFib. Why AFib? Because it causes a lot of clot issues and it changes the rhythm of the heart. Poor pulses and core extremity because the decreased cardiac output. The blood is being regurgitated back into the left atrium. So the amount of blood being pumped out of the aorta is being decreased. So we have a core extremity because there's not enough blood perfusing our extremity, and poor pulses because there's not enough blood going through the veins, the arteries. S1 murmur, again, S1 murmur is specifically to mitral regurgitation. So far we have S2 murmur is for mitral stenosis and S1 murmur is mitral regurgitation. It's very confusing, but we have to remember because it will be on the exam. We have to, guys. The heart has to work harder for adequate cardiac output, resulting in enlargement, dilation of ventricle, and initially leads to decreased cardiac output. Yes, I go over it a lot of time. So next we have aortic stenosis. So aortic is the aortic stenosis is talking about the valve between the aorta and the left ventricle. So before the left ventricle wanted to pump the blood out of the aorta, it has to go, the aortic valve has to open so that the blood can flow from the left ventricle to the aorta. Forward flow of blood through stiff stenosis. Again, stenosis is the door that is not open big enough for the blood to flow, because it was hardened, it was caused by rheumatic heart disease or inflammation of the heart or infection of the heart. Anything infection or anything inflammation regarding the heart will cause stenosis or regurgitation of the valve. It will result in large ventricle and unchanging cardiac output. Result in large ventricle. Why? Because the ventricle has to pump so much harder so that the blood can go out. Oh my God, sorry. So that the blood can go out of the aorta. Clinical manifestation: S1 murmur, dyspnea on exertion, angina, syncope on exertion, fatigue, orthopnea. Okay, so again, S1 murmur is the thing to remember here for aortic stenosis. Dyspnea on exertion, which means that like whenever we exercise or anything, we can have severely difficulty breathing, that dyspnea on exertion. Angina is chest pain. Syncope on exertion, you might feel fainted, you might feel like want to black out whenever you exert yourself, you run, you exercise. Fatigue and orthopnea. Orthopnea basically means that you lie down and you couldn't breathe, orthopnea. So S1 murmur. So we see a common thing here between aortic stenosis and mitral valve regurgitation. So it is important to remember. So aortic stenosis, S1 murmur, and mitral valve regurgitation is also S1 murmur. So highlight. Next, we have aortic regurgitation. Aortic regurgitation is backward flow of blood through incompetent valves. So when we talk about regurgitation, it is the closing of the door. The door is not closed hard enough. It's not closed completely. So the blood is being backflow to the ventricle, aortic regurgitation. The aortic valve doesn't close, so when the ventricle pump blood to the aorta, a little bit of the blood being regurgitated back to the left ventricle. And of course, whenever there is regurgitation, there are returning backflow of the heart. We will always have the issue with the lungs. It will cause pooling blood in the lungs, causes pulmonary congestion, crackles, bronchitis, fatigue, orthopnea, pitting edema, dyspnea, and S2 murmur, very important, S2 murmur. So we see the reason why they have, so we see the common thing here, S2 murmur in aortic regurgitation and mitral stenosis. Mitral stenosis, S2 murmur, and aortic regurgitation, S2 murmur. Okay, so aortic stenosis is S1 murmur, and mitral regurgitation is S1 murmur. And aortic regurgitation is S2 murmur, and mitral stenosis is S2 murmur. I know it's super confusing, but get it straight, guys. Nursing care for valvular heart disease. So valvular heart disease are the 4 things that we just talked about. That's why I tell you guys to focusing on the left side of the heart, the valve, because we only go over the mitral valve and the aortic valve. So prophylactic antibiotic treatment. So usually what that means is that when the patient is being diagnosed with inflammation of the heart, pericarditis, infective endocarditis, the doctor will prescribe prophylactic antibiotic treatment so that it doesn't damage the valve that lead to valvular heart disease. we have to fix the cardiac output. We give them digoxin, beta blocker, calcium channel blocker, ACE inhibitor, diuretic. These are very, very important medication. I really suggest you guys make a table, write down the time you guys need to give these med and what it helped and the big side effect of these med, because it will come up on the exam and the HESI. So digoxin will help the cardiac output by calming the heart down, reducing the heart rate. Beta blocker as well, calcium channel blocker as well, and yeah. Because these are Med-Surg I, so I can go over it later, but I was just going through this slide right now. Next, sodium restriction. Sodium restriction is because patient is retaining the fluid in the body already, not retaining the fluids, being backflowed and pooling in the heart. So the patient will have sign symptom of the fluid overload in the lungs, and you guys see pitting edema and stuff. So we don't want to ingest more sodium. It can causes retaining more fluid in the body and causes overload issues in the patient. Anticoagulant therapy. Anticoagulant, because the patient are forming clots and ampullae because of the regurgitated and pooling of the blood in the heart chambers. It causes form emboli, and so anticoagulant therapy are used for that. Surgical therapy, we have valve replacement and pre-op dental exam to reduce infection risk. So what that means is, like, before we do any valve replacement, we want to know why the patient have the valvular heart disease or any inflammation or infection to the heart. And usually earlier I said, I told you guys to highlight the the poor dentation. That is because it's one of the leading cause for these heart diseases. When the patient have bad teeth or bad dentation, it usually lead to heart issues. So with valve replacement, it either be artificial valve or human valve. They both have potential for leaking and risk for infective endocarditis. I don't remember she tests you guys on artificial or human valve, so I don't think we need to worry about it. Unless she talk to you guys tomorrow, let me know, but I don't remember she talked about any of those. And the patient must take anticoagulant therapy for life with artificial valve. Yeah, don't need to know that. Yeah, basically don't need to know any of those because we don't need to know about the artificial or human valves. All right, before I move on, is there any question at all? Or you guys feeling okay so far? I hope everything is helpful and making sense. Feeling good, awesome, thank you. Okay, right, now we're going to go over cardiomyopathy. Cardiomyopathy is when the myocardium, the endocardium, which are the layers of the heart, become hardened, causing dilation of the chambers, causes the chamber to get enlarged, dilated. Clinical manifestation is left-sided heart failure symptoms. So left-sided heart failure symptoms are the symptom related to the lungs. So pulmonary congestion, crackles, fluid overload in the lung. Diagnostic, BNP, Doppler echocardiography. Treatment, we have nitrates and diuretics. So BNP is the lab test. Will go up whenever the heart failure is present. Cardiomyopathy leads to cardiomegaly. It's basically the enlargement of the heart, and heart failure. Because when the heart is enlarged, it does not pump effectively anymore. That's why it considered heart failure. And left-sided heart failure symptom, again, are pulmonary edema, crackles, weak peripheral pulses. BNP, again, test the level of severity of heart failure. So whenever you guys see BNP, automatically think heart failure. Treatment decrease preload and afterload. Nitrates and diuretic decrease preload, they vasodilate or decrease the volume in the body, so the heart doesn't have to work as hard. Okay. All right, now we have shock. So cardiogenic shock. Cardiogenic shock, the pathology is low blood flow, causes myocardial infarction, cardiomyopathy, blunt cardiac injury. So these are causes of the blood not being perfused to the heart. So when the heart does not get perfused, it will go into cardiogenic shock. So remember this. So this is not the heart not pumping out enough blood. This is the heart not receiving enough blood. Clinical manifestation is tachycardia, low blood pressure, hypoxic edema. So tachycardia is because the heart not being received enough blood. So it tried to beat faster, so more blood will be able to reach the heart, perfusing the heart. So that's why have the tachycardia symptoms. Low blood pressure, hypoxic, and edema. Intervention, we have to restore the blood flow, cardiac catheterization ASAP. So cardiac catheterization, I said last week, cardiac catheterization is the visualization of the blockage in the artery. So they will go through your femoral vein, femoral artery in the thighs, go up that way, and to visualize any blockage of any of the artery that leading to the heart. And then they will do a procedure called PCI, which they mean that they will leave a stent at the blockage so that it can open the artery so the blood can flow through. Drug therapy, we have diuretic, nitrate, vasodilators, and beta blockers. Hemodynamic monitoring. Hemodynamic monitoring basically only means blood pressure, pulse, respiratory rate. So whenever we talk about, we need to do hemodynamic monitoring for this patient, basically just mean that we need to go and check the blood pressure, check the vital sign, check the pulse, and check the respiratory rate. Cardiogenic shock usually results in a low cardiac output because tachycardia, when the heart beats fast, it doesn't have enough time to refill the chambers, refill the left ventricle, so there's less cardiac output is being put out. And sign symptom of low cardiac output is weak peripheral pulses, cool and clammy. Intervention to help the body get circulation and oxygen. So we need to get the body restore the blood flow by the cardiac catheterization and the PCI procedure. And then we need to, of course, give the patient oxygen. Nitrates decrease workload by dilating. So we dilate the arteries that leading to the heart so that the blood can flow easier. Blood pressure, we need to, beta blocker, we need to reduce the heart rate and contractility. Beta blocker. Next, we have hypovolemic shock. So hypovolemic shock, the pathology is the pathophysiology is low blood flow from loss of intravascular fluid volume. So whenever we have a stab wound or we have internal bleeding, it can lead to hypovolemic shock. We lost the volume of the blood, causes hemorrhage, GI loss, third spacing, diabetic insipidus, hyperglycemia, diuresis. Third spacing, what does it mean? Third spacing is basically means that the patient might have issues with their liver, which causes the albumin to leave the artery or the vein. because in blood we have albumin, and when the albumin leave the artery or the vein going outside, the fluid will follow the albumin, which causes the fluid to be in the wrong spot. It's not inside the blood vessel, so that called third spacing. Clinical manifestation, the patient will be in a state of anxiety because no perfusion or oxygen go into the brain. They will have tachypnea, which is fast breathing, low blood pressure, high heart rate, low urine output. These shocks are very important. There's are like a couple of shocks, 4 shocks in total. I recommend you guys study everything from these slices. All the sign, symptom, and the clinical manifestation, the causes, and the patho, and how to treat them. High heart rate, low urine output. Treatment, we stop the bleed, we give blood or fluid, because I think Professor Lanasa mentioned a lot, whenever we lost a lot of blood, we have to give them fluid. And the fluid are isotonic fluid. If the patient have the issue with the third spacing, we give albumins and then fluid. But yeah, obviously first we need to stop the bleeding. Fluid volume loss result in decreased systemic volume, in decreased venous return to the heart, decreased preload, decreased cardiac output, decreased tissue perfusion, causes impaired cellular metabolism and cells death. Third spacing, fluid move from inside the vessel into the tissues and surrounding area, extravascular space. So we give albumin, avoid giving Lasix. So yeah, basically it's just like this is the blood vessel, and inside is the blood, and then the blood contains albumin. And the reason why the blood is able to maintain inside the blood vessel is because of these thing called albumin. And when the patient have issue with the liver, it causes the albumin to leak out of the blood vessel and into the surrounding area, the extravascular space. So that because the blood and the fluid is being leaked out, we don't have the volume inside the artery anymore. It causes hypovolemic shock. That's basically the meaning of third spacing. Next, we have neurogenic shock. Neurogenic shock is spinal cord injury, results in massive vasodilation, leading to pooling our blood in the vessel. Clinical manifestation, bradycardia, can't regulate body temperature, dry skin, hypotension. So we have going so far, and we all of the cardiogenic shock and hypovolemic shock. The big side is the tachycardia, but neurogenic shock is the only one. It is bradycardia. When we mention about shock, there are 4 types of shock, and the only one that have bradycardia is the neurogenic shock. So please remember that. Can't regulate body temperature. Why? Because there's issue with the spinal cord injury, and the regulation, the temperature is the job of the what is called hypothalamus or something like that. Yeah, but it's in the brain, so it's regulated temperature. So if we injure that area, we cannot regulate its body temperature no more. Do you have dry skin? Do you have hypotension? Yeah, bradycardia and hypotension. Treatment, the cause, we stabilize the spine. If they have a spinal injury, give medication for hypotension and bradycardia. We can give them vasopressor and atropine. Remember last week I talked about atropine. Atropine is given whenever the patient have bradycardia. So if there's an exam question that saying that the patient is showing symptom of sinus bradycardia, what is the treatment? We give atropine. Okay, and only give atropine if the patient shows symptoms. If the patient is an athlete or does not show any symptom, no treatment is needed. sorry, I go off topic. Do not give a lot of fluid. We do not give a lot of fluid in this patient. Monitor for hypothermia. We give them warming blanket. So neurogenic shock is a distributed shock. It is associated with cervical or high thoracic injury. With vasodilation, you get hypoperfusion, impaired cellular metabolism. The reason is hypoperfusion is because the blood vessel is so dilated that the blood doesn't have enough pressure to go up to perfuse or going back to the heart. So that's why it causes impaired cellular metabolism. If you can't regulate the body temperature, think of the intervention that will help decrease hypothermia. For example, giving warm blanket, warm the IV fluid. Vasopressure is to maintain the blood pressure and perfusion. Vasopressure is basically just means that it narrower the blood vessel. Atropines for bradycardia. Fluids are given cautiously because this shock is not related to fluid loss. It is related to nerve and regulation damage. That is the reason why. So we give fluid only if the patient have hypovolemic shock. And we give blood if it's cardiogenic shock. We restore the perfusion. And we do not give fluid if the patient have neurogenic shock, do not. Next, we have anaphylactic shock. I think we all know this. Anaphylactic shock is mentioned a lot. It is an allergic reaction to something that foreign to the body. It's usually acute, life-threatening hypersensitivity. Clinical manifestation, the patient suddenly feel like an impending doom. They will have lower back pain because of I think it's something to do with the kidneys. They will have hives, lip swelling, pruritus, flushing. They'll have respiratory issues, coughing, wheezing, stridor, shortness of breath. GI, you have abdominal cramping, diarrhea, cardiovascular, they'll have weak pulses. Neuro, they'll have decreased level of consciousness, increased anxiety. Treatment, airway. So we have to make sure that this airway is patent, because sometimes somebody might allergic to peanuts and they eat peanuts, their airway can be blocked and the bronchioles can get inflamed. So we have to make sure that the airway is not blocked. We can give them Benadryl, epinephrine, and fluid replacement. Low back pain often seen with transfusion because remember where the most of the blood is produced as an adult. Oh, okay. So so anaphylactic shock can happen when we do blood transfusions, and low back pain is often one of the biggest size. We can tell whenever the patient is develop a hypersensitivity to the blood that is being transfused to them. If that happens, the first thing we need to do is stop the transfusion and take off the line from the patient before we do anything else. That is the priority nursing intervention. Stop the perfusion. Where's the most blood is it being produced in an adult? It is in the sternum and also the iliac crest. So there's two places on the human body that produces erythrocyte, which is the bone marrow, and the bone marrow is located in the sternum and the iliac crest. Anaphylactic shock leads to vasodilation and increased capillary permeability. That's why you see hives and swelling. In respiration system, it causes edema and bronchospasm. Yes, so it causes crackle in the lungs and the bronchioles get swelled and spasmodic spasm. Septic shock. Septic shock is the shock relating to infection. So it is an infection that left untreated or too severe that the infectious disease got into the bloodstream and spread all over the body. Clinical manifestation is Increased temperature. So why increased temperature? Whenever we have an infection, it's only increased temperature. So yeah, hallmark sign of septic shock is increased temperature because infection. Persistent hypotension. So the patient will remain really hypotensive. Their heart rate is increased, decreased urinary output, GI issues, increased respiratory rate. The patient could go into respiratory alkalosis. The reason why respiratory alkalosis is because whenever the patient is in septic shock, they will present increased respiration. Whenever we're breathing too fast and too much, we expel too much carbon dioxide. And carbon dioxide is what makes the blood acidic, more acidic. So we don't have the level of carbon dioxide is too low. That's why the patient can go to respiratory alkalosis. Normal level of carbon dioxide is 35 to 45. Yeah. Treatment, fluid replacement. Treatment for septic shock is fluid replacement. We give the patient fluid, we watch the blood pressure, we give the antibiotic, and we give vasopressor. Vasopressor is very important because the patient with septic shock have very low blood pressure. GI issue because of decreased circulation leads to GI bleeding and paralytic ileus. Give isotonic crystalloid, which is just normal saline, 0.9% normal saline, that's what that is. Vasopressor to help with circulation and increase blood pressure. Antibiotic given at first is broad spectrum because the patient is in a shock crisis. So you need to fix the shock first so that they can live long enough to get the antibiotic. And testing for the pathogen can take up to 3 days. So what it means is, first and foremost, we're going to get a blood culture to see what specific pathogen is being invaded or being in the body. And then we give immediately after we get the blood culture, we give the patient broad spectrum antibiotic. And then after we get the result, we give the patient the specific antibiotic that treat the specific pathogen that are shown in the blood culture. Next, we have SIRS, systemic inflammatory response. So systemic inflammatory response is general inflammation in the organs. Prevention is pre-shock. So all of the shock, and especially septic shock, can lead to shears. Trigger is sepsis, endotoxin release. This shears can lead to multiple organ dysfunction syndrome. Very quick response, respiratory system is usually affected first. Shear is a response to infection, ischemia, infraction, and injury. Injury. Next, we have MOD, multiple organs dysfunction syndrome. Multiple dysfunction organ syndrome is the failure of 2 or more organ systems due to the ineffective treatment of shears. So usually sepsis, it will lead to shears, which is the systemic inflammatory response. This is when the whole body is on the go into the inflammatory stage, and then the result of that will be the failure of 2 or more organ system. So that is really important. So if we have only the kidney is failing us, that is not considered MOD. That is still considered SIRS because the patient is having a systemic inflammatory response. But whenever they reach 2 or more organ system failing, for example, the heart and the kidney, or the liver and the kidney, it will be considered MODs. If not fixed, the patient will die. Clinical manifestation depends on the organs involved. Hypotension, bradycardia, emboli, liver issues, AKI, alveolar edema, mental status changes. Treatment, fix infection and maintain oxygen need, maintain nutritional and metabolic support. Patient with MOD will need more oxygen and will be vented, meaning ventilated. Will have NG tube or enteral feeding. Nutritional support is needed because at the moment the body is in hypermetabolic state because it's working overtime trying to get all the organs its circulation it needs. It just basically means that whenever the body is experiencing MOD, it required a lot of energy and it's consuming a lot of calories. So we need to give the nutritional support for the patient either through an NG tube or enteral feeding. Okay, so that's pretty much the content that we need to go over today. Before we do the question, do you guys want to take a break first? Do you guys have any question for me or anything before we take the break? No? So I'll say we have the break for 10 minutes. So we go back at 5:07. Oh yes, I will be posting the PowerPoint for you guys. You're very welcome. All right. You're welcome. I hope everything making sense. I will be back at 5:07. I'll see you guys then, and we just do some more question. There's probably just a few questions. It won't take long. Okay, 5:07. Okay, guys, we're back. There's a few questions that we can practice and going over right now. I know we just go over the information, so you guys may not know the answer, so don't get discouraged or don't get frustrated because you guys just literally just go over the information. So this question we're going to practice right now just to reinforce the knowledge, and you guys can definitely go over them because I will post the PowerPoint on the Facebook group, okay? All right, I hope everyone is back. So we will go ahead and start with the first questions. The nurse is monitoring a client with acute pericarditis for signs of cardiac tamponade, which assessment finding indicates the presence of these complications. A little hint is pericarditis is the infection of the sac around the heart. Okay. I'll wait for one more answer and I'll show the result. Perfect. You guys are correct. Muffled or distant heart sound. Assessment finding associated with cardiac tamponade include tachycardia, distant or muffled heart sound, jugular vein distension with clear lung sound, and a falling blood pressure accompanied by pulsus paradoxus, a drop, which is a drop in inspiratory blood pressure greater than 10. Yeah, the other options are not signs of cardiac tamponade. Flat neck veins is not correct because it causes jugular vein distension. A pulse rate of 60 beats per minute is normal, and wheezing on auscultation of the lungs is usually associated with asthma. Wheezing is asthma. Next, we have the registered nurse is educating a new nurse on mitral valve, mitral stenosis, which statement by the new nurse indicate that the teaching has been effective. Okay, we have answer number 2. So left atrium to left ventricle narrowing will impede flow of the blood. Correct. So mitral valve separated the left atrium from the left ventricle. The remaining option describe impeded flow due to aortic, tricuspid, and pulmonary stenosis, respectively. So like I said, it's mitral. That's why we need to really know the mitral is the left side of the heart. First answer, left ventricle to aorta, narrowing impeded flow of the blood. So what is the valve between the left ventricle and the aorta? The aortic valve. So that's wrong. Right atrium to right ventricle. Right atrium to right ventricle is the tricuspid valve. Right ventricle to pulmonary artery is the pulmonic valve. And whenever it's narrowing and impeded the flow of the blood, it is stenosis. The door is not open big enough. Next, we have the registered nurse is educating a new nurse about aortic returgetation. Which statement by the new nurse indicates that the teaching has been effective? Okay, so I have 2 answers. And yes, number 1 is the correct one. The aortic valve separated the aorta from the left ventricle. The statement in remaining option are incorrect. So failure of the aortic valve to close completely allows the blood to flow retrograde through the aorta to the left ventricle. The question is about the aortic regurgitation. So regurgitation is that the door. Sorry guys, I'm having some problem. Let me stop share real quick. And okay, sorry about that. Yes, so regurgitation is that the door is not closed good enough, not closed completely. So that's why it causes the blood to backflow to the left ventricle. Next question, we have the new register is orienting on the cardiac unit. Which statement by the new RN indicate an understanding of an early indication of fluid volume deficit due to blood loss? Fluid volume deficit. Okay, we have 1 answer. Okay, I'm just gonna go to the answer choices. It's going to be the pulse rate will increase. Yes, so immediately we can cross out edema and crackles. So we all got stuck here at the pulse rate and the blood pressure because they are both correct. In the hypovolemic shock, whenever we lose this blood, the heart will increase and the blood pressure will decrease. But the early indication, which is the first thing that's going to happen, is the heart rate will increase first. So the cardiac output is determined by the volume of the circulating blood, the pumping action of the heart, and the tone of the vascular bed. Early decrease in volume fluid volume are compensated for by an increase in the pulse rate. Although the blood pressure will decrease, it is not the earliest indicator. Edema and crackles in the lungs indicated an increase in fluid overload. Here we're having a fluid deficit. So just remember the heart rate will go up before the blood pressure going down. Next, we have the nurse is caring for a client hospitalized for heart failure exacerbation and suspect the client may be entering a state of shock. The nurse notes that which intervention is priority for this client. Okay, so we have two answers. So I'm just gonna move ahead. And the answer is one. The client, this is a hard question. So the client in this question is likely experiencing cardiogenic shock secondary to heart failure exacerbation. The reason why number three, the administration of IV fluid is not correct because it is not hypovolemic shock. If it is hypovolemic shock, we give fluid first. But this is the cause of cardiogenic, but is this the sign of cardiogenic shock? If we read the question again, heart failure exacerbation. So whenever the patient have heart failure, the heart doesn't pump effectively, so it decreases cardiac output. When there's not enough blood circulating, the perfusion of the heart will be decreased. So when the heart is not being perfused, it will exacerbate as heart failure. It will exacerbate, put the patient in the cardiogenic shock. It is important to note that if the shock state is cardiogenic in nature, the infusion volume expanding fluid may result in pulmonary edema. Therefore, restoration of cardiac function is the priority for this type of shock. Cardiotonic medications such as digoxin, dopamine, or norepinephrine may be administered to increase cardiac contractility and induce vasoconstriction. Whole blood, IV fluid, and packed red blood cells are volume expanding fluid and may further complicate the client clinical status. Therefore, they should be avoided. So earlier I say give blood for cardiogenic shock is incorrect. Sorry about that. So we don't give blood or fluid to cardiogenic shock. What we give is we give the medication such as digoxin, dopamine, and norepinephrine. Dopamine and norepinephrine will have a vasoconstrictive effect, which will help the blood being perfused more to the peripheral and the heart itself. Digoxin will help enhance the contractility of the heart because in the cardiogenic shock, the heart doesn't pump effectively. The digoxin will slow the heart down and make sure the contract is effective. So that's why we administer digoxin for patients who exacerbate the signs and symptoms of cardiogenic shock. Okay, so next week we will go over respiratory failure and mechanical ventilation. Before we end the tutoring section, does anyone have any question or any comment that they would like to share to me? I hope everything today makes sense, and I hope you guys like the tutoring. Thank you. You're very welcome, guys. So feel free to leave the session. You will be doing a review next week for the exam. Yes, I will do a review next week for the exam. Definitely, it's going to be on the same Tuesday at this time. If you guys in the cohort want a more session on the medication or anything like that, please let me know. I can do another session before the exam like that too, maybe before the end of this week or anything like that. So just let me know. But definitely we will do a review session on Tuesday next week. And tonight I'm going to post this PowerPoint and also the Kahoot link, which have some questions, practice question of Med-Surg II exam on there, so you guys can do it and review for the exam before my session next week. You're very welcome. You guys, thank you. You guys feel free to leave. And if you have not scanned the code, here's the code scanning. And thank you very much.